Make it in full screen.
Is it okay?
Yes, yes, sir. It is better. Just give me a minute, sir. We are going live now. So we are live now. With all your due permission, we are beginning with the session for today. Good afternoon, everyone. This is Batul from IGCP, the moderator for today's session, and I would like to welcome everyone wholeheartedly at our platform for the better exchange of knowledge that is going to be shared by our stalwart who is present here with us today. So now, without any further delay, I would like to welcome our renowned general physician, who is none other than Dr. T.N. Ravi Shankar, sir. Sir is MBBS, DFN from Colombo, FCGP, PGDMD, MBA, family physician at Sudhar Hospital, Chennai. With sir's wonderful insights, we are going to talk about the topic for today's discussion. And the topic for today's discussion is transfer of critical patients. So now, without any further delay, I would like to welcome Sir at our forum and would like to hand over the session to him for his precious talk to begin. So over to you.
Thank you, madam. Thank you, IGCP, Dr. K.K. Agarwal and group for having given me another opportunity on this afternoon to talk to you on another important topic of transfer of critical patients. I think it might sound something which is so simple and easy job, but quite a number of times things have happened the other way when you are trying to transfer patients. Transferring of patient can happen in so many situations. Till the patient reaches your hospital at your front office or the front door, wherever it is, it's a responsibility of the family or the person who's bringing down the patient to you, and it is their responsibility to keep the patient intact, alive, ambulant, and all fine. Anything that happens within the hospital, it is the responsibility of the hospital and the primary care treating physician to see that everything goes perfect for the patient. One of the critical aspect in NABH accreditation is also the transfer of critical patients within the hospitals or in transferring it out of the hospital. There are certain things that need to be followed or taken care when you are trying to transfer a critical patient, and that is what we are going to see today. Just to update ourselves on a hard weekend, or in fact a financial year closing, that everybody in the corporates will be talking about that finance, but today we are trying to talk about the important of aspect of patient transfer. Intra and inter-hospital transfer, it aims to maintain or continue the medical care of the patient, whether it is going to be within the hospital or if you are going to transfer it to an elsewhere to the Hyatt Center, or the patient might be going to their own home. But till the patient reaches the home, it is a responsibility of the hospital to keep the patient intact, alive, ambulant, whatever it is that the patient expect or the family expect. A poorly organized and hastily done patient transfer can significantly contribute to morbidity and mortality. Things have to be taken care at every steps. Written and informed concerns of patient's relative along with the reason to transfer is very much mandatory before we take the effort to transfer the patient. You need to communicate directly with the patient if the patient is alive and conscious to take a decision, or their next kith and kin who have been authorized by the patient or who have the legal right to take a decision on behalf of the patient if the patient is not conscious or unable to take a decision. Very, very important is if the patient is going to transfer to a different ward, to the ICU, or from the ICU to the ward, the receiving center also will have to receive the information that the patient is going to get transferred there, be it within the hospital or transferring to a hospital outside your premises. You might be transferring to a tertiary care center or even a primary care center, and the patient can't afford, they might switch over to a primary care center for maintenance of life. Even then, you need to give a proper information to the receiving hospital. Sharing of complete information on patient's clinical condition and treatment given is the utmost important. I think the MCI, or you might say the NMC, has now given the guidelines that within 3 days you need to give the information, but when the patient has to be treated elsewhere. It is our primary responsibility to share the information about the patient and the treatment at the time when the patient is being transferred. The reason for transfer, the mode of transfer, and the time taken to transfer also will have to be shared so that the receiving place is ready for to receive the patient with all care and caution. Stabilization and the time is very important. Adequate resuscitation and stabilization to the maximum extent possible without wasting undue time. You might have a primary or a secondary care center. We don't have a coronary angiogram, but you need to stabilize the patient. The patient has got low pulse volume, bradycardia, unconscious, whatever it is, to try to resuscitate the patient appropriately. Maintain the airway with the ventilator, or an intubation or whatever it is. Maintain the breathing with your ambu bag, circulation by your IV fluids. Assess the situation of the patient. Note it down when you are trying to refer the patient. If it is going to be a neurological patient with a neck injury or a stroke or whatever it is, try to assess the neurological status in the 2-3 minutes that is available to you. Note it down and transfer the information. Transferring of the information is very, very important in every situation. The transferring mode may be a basic life support, the usual ambulance that is available everywhere, where there is a person to receive the patient within the ambulance, somebody who sees the patient if there is a monitor or IV fluid that is flowing to take care of it. There may be an advanced life support where the ventilator is also available within the ambulance with monitor and all the gadgets available. It's almost a ICU, and that is called, the next one is called the medical intensive care unit within the ambulance. The ambulance need to be a bigger variety. There need to be space for people to walk around and do certain procedures in the case of an emergency. Air ambulance is another one that is there in this country, available, but cost is a little high. But air ambulance is there for all VIPs or certain patients who need to be airlifted from one city to the next city, or from a 2-tier city to the tertiary care center for maintenance of life and for certain treatments which may not have been available in the 2-tier or 3-tier cities. Air travel has to be taken care with utmost importance. There are certain things which need to be taken care. The flying condition, even for a normal person at times, may be difficult. And if it is going to be a patient, you need to assess the patient, the environment within the aircraft, the environment that the patient can tolerate. There may be uncooperative patients who might need to be sedated before they are taken into the aircraft. Untreated pneumothorax will have to be identified, because if there is going to be a pneumothorax and if there are going to be air taking off, that can cause negative pressure and make the lung collapse, or even rupture of the pneumothorax is possible when there is a low intra-aircraft pressure which raises up once the aircraft goes to the higher level. The penetrating eye injuries then can become deeper if in the transfer during the flight's takeoff and going to the higher altitudes. Patients with recent abdominal surgery who might need some more intervention in the tertiary care center in a different city has to be carefully handled. It can cause bleeding. It can cause intra-abdominal accumulation of fluid also. Potentially obstructed airway and respiratory distress, like how you treat a pneumothorax, has to be given care and caution when you are going to be airlifted. It's always a problem when the aircraft is taking off and when the aircraft is landing. With a significant facial injury and reduced conscious level also need to be taken care whenever there is an air travel involved for a patient. You need to classify a transferring patient. The need for number of persons to accompany is based on the classification of the patient. 2 competent persons needs to be accompanied at every situation, even if it is in an air ambulance or in an ambulance on road. Level 0 is a stable patient who can be taken care of by any supporting medical staffs. Level 1, which can deteriorate and transfer and needs competent person to be accompanied. More often a qualified ICU staff or in fact a medical officer need to accompany to these level 1 patients to be legally safe, keeping the patient alive. Let the receiving hospital to receive. Even if you have given all the information, if the patient is not within a proper status and unstable, the receiving hospital will not be willing to receive such a patient. Level 3 need advanced respiratory support. Doctor must accompany, and you might also need a ventilatory support. You need to have some checklist before transferring a patient, be it an ambulance or whatever it is. The drugs, the emergency drugs that are available within the ambulance, and the drugs which need to be accompanied. The IV fluids that is going on will have to be maintained, and supporting IV fluids will have to be there. You need to anticipate for a traffic jam. If there is going to be a problem somewhere, something going on the road, and that too hereafter is going to be an election for the next 2 months, anything can happen in the roads. So you need to be careful. You should not leave the primary hospital without adequate drugs stocked in the ambulance. The equipments will have to be perfect, functioning. The personnel must be qualified. If there is going to be invasive BP in setting at the patient, that need to be monitored properly. More than that, please see to that the level of battery of your monitor or the respirator that is being kept in the ambulance is secure, recharged, or there is a support for it if there is a fall in the battery level. It's a very, very important, the drug and keeping the level of the monitor's battery adequately. A standardized document should be used and maintained both for intra and intra-hospital transfer. The reason, the condition, the vital chart, the drug used, the time, mode, the accompanying persons, what are the investigation that has been done, results awaited, all these things should be documented. Without a document, nothing can work perfectly in a hospital. What are the complications that can happen during a patient transfer, be it on the road or air? We already seen what can happen in an air ambulance. When there is going to be a long duration of transfer with no proper AMBU bag available, and if there is no proper person to AMBU, the patient can go in for hypoxia, can go in for pulmonary atelectasis. The hypoxia could have been a result of a pulmonary embolism had it not been diagnosed earlier. Bronchospasm, pneumothorax, cardiovascular shock can happen. Some patients have the motion sickness, and if they are conscious well, they might land up with a little bit of raised BP. Some can have hypotension, arrhythmias if the primary problem is cardiac, and if you don't have done the proper resuscitation before shifting the patient onto the ambulance, a cardiac arrest is imminent in cases which have a low pulse volume, poor BP, not on inotropic efforts. Hypoglycemia, hyperglycemia can happen. Ventilator-associated pneumonial infections and all these things, as what can happen in an ICU, can also happen when the patient is shifted for long duration. There might be a tertiary care center in a far-off place. You might have to travel for 100 to 150 kilometers. Definitely, it might take an hour or more than an hour. If the roads are very clear, it might take 1 kilometer a minute or 2 kilometers in a minute, but still you need to anticipate all these problems, even an acid-base disorder, acidosis or respiratory alkalosis. And sometimes, if the ambulance doesn't have a proper shock absorber, or if the roads are not well maintained, and if there is a lot of bumpy roads, dislodgements of the monitor falling off onto the patient also should be monitored, and all the monitors should be tied up in the ambulance appropriately and properly. Even this, within the hospital transfer, the monitor will have to maintain properly. The oxygen cylinder also should accompany when the patient is wheeled out on a stretcher. Today we have stretchers where the oxygen cylinders can be kept along with it. And these are things made easier for them. The risk factors for patient is high positive end expiratory pressure. If it is done more than 6 millimeters of water, patients can have problems. Patients with coronary artery disease on transfer can still have problems. Post-operative patients, such as a severe trauma patient on complex medications and on infusion regimens, if they are not being maintained properly within the ambulance, can also result in hypotension, arrhythmias, or whatever it is. You need to maintain the IV fluids. You need to maintain the drugs even when you are shifting the patient on an ambulance. And if the time to give the certain medications, even if it is antibiotic, will have to be maintained in the ambulance, and proper documentation and proper information should be given to the personnel within the ambulance. Staff related, if they are inexperienced staff, unfamiliar with monitoring equipments, Insufficient preparation of the patients can always land up with more problem. Poor communication with the receiving facilities or from the primary center can cause a lot of problems. Inadequate resuscitation. Sometimes you do some massage, you see a QRS complex coming in, you just want to shift the patient out of the hospital. You shift the patient hardly 2-3 kilometers outside the hospital, patient might have a flat line. See to that the patient is properly resuscitated and there is a proper QRS complex and a proper BP recorded before the patient is shifted onto the ambulance. Lack of checklist failures to prepare monitoring before transfer and interruption of the therapy is one of the causes of patient dying within the ambulance. You need to have a proper belt, drawing sheet, Hoyer's lift and a slide board when you are trying to transfer the patient into the ambulance or out of the ambulance. Hoyer's lift is something which are most commonly used within the hospital, where the patient can be lifted, sit on that mobile unit, shifted from bed to bed, from ward to ward. Sometimes that is also be useful trying to shift the patient. If they can't wheel down on a chair, they can be taken in the Hoyer's lift into the ambulance also. Transport complications on road where the patient is going to come from a hill station down, the attitude, the vibrations that can cause when the ambulance is moving. The acceleration of the gravity, a sudden jerk in the ambulance. You stop the ambulance because there is something traffic hazard and the driver could not move around. All the drivers of the traffic of the ambulance need to be trained on that the movement here and there and the acceleration should be gradual and it cannot be too forcefully given, because that force can always cause a problem for the patient's conscious status and their CSF mobility can be haphazard when they are being accelerated too fast or too slow. Temperature, hypobaric hypoxia are some of the complications in transport. Third space loss is quite common in an air ambulance transfer or when the patient is coming from uphill down or when they are going from down to up the hill for their back to the residence or something like that. Gas changes in body and equipments, pressure necrosis, motion sickness all need to be carefully monitored when the patient is on transport. Practical issues that need to be seen is communication within the hospitals. I think I have told too much about it. Movement in casualty had to be minimal when they are shifting the patient from the bed onto the stretcher and into the ambulance. There can be scars and need to belt used properly and straps used properly when the patient is mobilized on the wheelchair or on the stretcher into the ambulance. Overweight patients need to be taken care carefully. Some of the time, most of their limbs will be falling off the stretcher that can cause injury to the patient either on the wheel or on the floor, and the staff will have to be taken care of those patients adequately. Oxygen supply to be maintained even when they are wheeled out of the casualty into the ambulance. Equipment faults will have to be found out. Regularly monitoring it is very important. When you are going to wait in front of a lift, it's going to be time consuming. And if the patient has to be shifted out of the lift, you need to keep the lift waiting in the ward before you shift the patient out of the ward or shift the patient onto the stretcher. Ambulance, primary or receiving SAM, receiving hospital formalities, sometimes they refuse if the patient is collapsed on travel because it involves giving a death certificate, it involves trying to convince the attenders, and a lot of things of emotional thing can happen. Settlements and delay of the bill is one of the reasons when most of the time the patient is shifted into the ambulance and then something happens in the ambulance, that's a problem. Before you wheel the patient out of the ER, out of the ICU or the ward onto the stretcher, make sure the bills are settled and there is no delay in the front office to shift the patient. It is very important to have a mock drill of shifting patients in the hospital at least once in 3 months. NABH accreditations insist on on such a mock drill that is happening, because if this is not being done regularly, your ward boys, your sisters might lose some of the techniques that need to be done during the transfer of patients. Let's see some of the legal issues that have happened during shifting of patients. It's a small process, but the process can result in a lot of problems. I'll go through the slide. Even in some of the these are statements that has been pronounced in the judgments. Even in the ambulance, giving oxygen was delayed because the oxygen was not pumped through the ambu bag, and this delay further aggravated the situation, resulting in the patient having no recordable pulse or blood pressure when she received the receiving hospital. Then the receiving hospital is not going to receive the patient, and it is the primary hospital that will have to go and convince the attenders what has happened. In his affidavit filed as a medical expert, clearly stated that it was shocking that the anesthetist failed to accompany the patient in transfer to Chennai Kaliyappa Hospital after alleged re-intubation, since it is the anesthetist who is responsible for immediate post-operative care. When there is re-intubation, difficult in respiration, I think the anesthetist will have to accompany, because at that point of time, the primary hospital probably does not have a ventilator. The anesthetist will have to accompany, intubated, and moving the patient, whatever way it is there. When the patient is breathing difficulty, oxygen, giving ambu is very, very responsible. The respondent doctors were guilty of gross medical negligence and deficiency in service in not checking these facts before shifting the patient to the receiving hospital. This resulted in a compensation to be awarded by the primary care hospital. More than that, the court went to the extent of saying, if you don't have a ventilator, don't venture to do surgery, which is practically not possible in a secondary care or a tertiary care towns. 2-tier or 3-tier towns, it is not possible for every hospital to have a ventilator. And if court started giving judgments like that, then no hospital will be able to venture into doing a surgery without a ventilator, which involves another huge investment. In case of critical patients, even minor action like shifting to ambulance should be done in a sense of urgency. No delay should be there. Not only negligence, but also infatuations that attenders sow the seed of disputes. If there is a slight delay, if you try to delay because of the bill not paid, then this is all things that can crop up a problem if we lose a patient en route. Ensure proper arrangement of oxygen supply in the ambulance during transfer. Allegations of 10 minutes delay, no proper supply of oxygen, and ambu bag. Quite a number of times the ambu bag in the ambulance are not being checked properly. There might be a tear. There might be inadequate connectors, which can result in problem or delay or air leak when you are trying to give it. Delay in shifting a patient to another facility when indicated should constitute as a medical negligence. This was one of the judgments from a national commission. Transferring a hospitalized patient to another hospital without proper medical justification is always viewed suspiciously by the courts as an attempt by the doctor or the hospital to escape legal liabilities. The issues may be on payment, death, and uncooperative attenders. Be careful, be justifiable when you are trying to shift a patient to another hospital. Your problems cannot be shifted to another hospital if you cannot handle it on payments or convince the patient that the treatment that they are provided is adequate. It might happen that the receiving hospital at some point will not be able to convince, can put down a word here or two, which can result in complications for you. The secondary hospital escaping from the emotional warmth of the patient, and the primary hospital receiving the legal notice and all the problem. There's another judgment. Ambulance have requisite facilities. No pacemaker in the ambulance, dismissed on technical grounds. The allegation was that the patient's attender wanted a pacemaker in the ambulance. I think which is practically not possible in this country or anywhere. I don't think pacemakers are being done or being provided in the ambulance. And this was dismissed on technical grounds by the court. I think if you give a proper documentation, valuation for what the allegation was, the courts will always make it justifiable. Thank you for your patient hearing. And I was trying to give an overview of the caution that need to be taken for shifting a patient. And I did not try to pretend giving some of the court judgments. Judgments in the court are only a lesson for us to follow so that the problem that happened for somebody doesn't happen to you. Thank you, IJCP, for the opportunity.
Thank you so much, sir. Thank you for your overwhelming talk that you have shared on our platform and for sharing such wonderful insights with us. Thank you so much for that. We have received few questions from the participants, so with all your due permission, I would like to put across those questions to you. So the first
Please.
question, hello?
Yeah, please.
Yeah, the first question is, what are the common challenges encountered during the transfer process of critically ill patients?
I think I have already told. My
Yes.
primary issue is resuscitating the patient adequately before you shift the patient. I always say just 2 minutes watching the QRS complex, whether it is proper, whether the breathing is shallow or the breathing is adequate. See to that your respiratory system and the cardiac system is proper at least 10 minutes in the primary hospital. Before shifting on to the stretcher, see to that the monitor, the oxygen supply, and the ambulance is perfectly ready there. More than that, the personnel accompanying the patient should have adequate knowledge about the patient, handling the equipment, and taking care of emergency. That's a very, very important thing that we need to know. Yes.
Thank you so much, sir. Thank you for answering that question. We'll move to the next question, and the next question is related to the psychological impact. So, what measures can be taken to address the psychological impact of transfers on patients and their families?
We need to say appropriately. See, most of the time when you're trying to shift a patient from a one center to another center is for want of certain medical facilities. It may be ventilator in a very small three-tier city. It may be for a coronary angiogram in a two-tier city. It may be for a much better transplant or much better surgery, ECMO or whatever it is in a tertiary care center. There are two things that involve that the guarantee, the support that you give for during the transfer, and the transferring out to the next center, the availability of the medical care, which is going to make the patient recover or bring back to normalcy. These are things that has to be reassured. It is not that we are trying to shed off our responsibility and shift the patient to another center just for want of finance, just for want of transferring the problems to the next center. Make sure, assure the patient that the patient is getting shifted to the next center, primarily for the total recovery and for bringing back to normalcy. This is the emotional support that we need to give to the patient as well as to the attenders when you're trying to shift a patient to another center. More often, it is for the tertiary care services.
Thank you so much, sir. Thank you for answering that question. We will move to the next question. And the next question is related to the technology or techniques that improve the transfer. So, what are the latest advancement in technology or techniques that improve the transfer of critically ill patients?
I don't think there is anything special. Everything goes on. Probably today we have slide boards which are mechanized. The cot and the stretcher coming on level. There are slide boards where you can slowly shift the patient without lifting the patient. Go into the ambulance, from the ambulance again to the receiving hospital. You have the hose lift. You have the mechanized sliding boards. These are things, the primary problem that happens in shifting is you don't have proper people. At least there should be 6 people to carry a patient without any difficulty. Somebody on the head, on the neck, on the shoulder, both the arms to be taken care, the hip has to be taken care, the limb, the end of the foot, all these things has to be taken care appropriately. There need to be 6 persons, 3 this side, the 3 other side to take care properly. And today we have a lot of mechanized things, and these mechanized also become digital today. And these are things that are available in most of the tertiary care centers to shift the patient with the least trauma to the patients, even to the muscle or to the bone or whatever it is. There are times when small shifting of the patients can result in respiratory distress or can result in cardiac arrhythmias. And these things can be done in these kind of ambulances which are available. Maybe tertiary care centers and the major metropolitan cities and tier 1 cities have all these facilities, all mechanized. You don't need a ward boy or IAS or manual to shift the patient. Everything happens mechanized. That is available today. That is the latest in transferring the patient today.
Thank you so much, sir. Thank you. Thank you for answering this question and for making our viewers understand about the topic better. Thank you so much for that. And I would like to thank all of our viewers for their ardent participation that they have shown by staying tuned with us throughout the session and putting across such interesting questions to us. And I would like to thank you, sir, for taking out your valuable time and for being here at our platform and sharing us the insights with us. Thank you so much, sir.
Thank you. Well, thank you. Thank you all. Thank you all.
With this, we are concluding the session here for today. Until next time. Thank you, sir.
Thank you so much. Thank you so much.